My name is Dan Reisman. Good morning. Today with us is Dr. Dan Milder, an Australian neurologist. Good morning, Dan.
Good morning.
Could you describe your views as expressed in your publications?
The publications deal with the cause and nature of progression of the common degenerations, Alzheimer's disease, Parkinson's disease, and motor neuron disease, and an approach to therapy. The thesis states that a particular cell, the microgliocyte, is common to progression in all these diseases. If it attacks cells that synthesize amyloid, Alzheimer's disease results. If it attacks cells critical to Parkinson's that contain alpha-synuclein, Parkinson's disease results. If it acts on cells in the spinal cord and brain that govern the contraction of muscles, motor neuron disease results. So in effect, a form of autoimmunity, the body acting against itself, the disease reflecting the different parts of the central nervous system which these particular cells, the microgliocytes, attack.
I understand. This derives from your clinical observations.
In progressive multiple sclerosis, that's true. In progressive multiple sclerosis, it is held that the same cell, the microgliocyte, is critical to progression. A number of patients with progressive multiple sclerosis with visual disability were found to reverse on a particular combination of therapies. In progressive multiple sclerosis, the effector cell is held to be the same, the microgliocyte. So the thesis derives from these observations.
Mm-hmm. I understand. Are you aware of any other coherent accounts of the causes?
I'm not aware of any other coherent accounts. The thesis, I think, states, likely for the first time, an understanding of the cause and nature of progression of these diseases and a rational approach to therapy.
Now, you have advocated for a certain therapeutic treatment for these diseases. Can you explain this?
The therapy that's been used is a combination of azathioprine, also termed Imuran, with either gluteramine acetate, also known as Capaxone, or one of the four forms of interferon beta. And it has been found in some patients with progressive multiple sclerosis to have a beneficial effect that can be measured by reversal of vision, or rather visual disability. That's ordinary vision and color vision.
Mm-hmm. And how did you come up with this therapeutic observation?
The initial patient was a young woman who had declined progressively over a year and a half. At the end, she was completely paralyzed and completely blind. At that time, there were very few medications for multiple sclerosis, or progressive multiple sclerosis. And so one of the usual medications, gluteramine acetate, was added to azathioprine. To my surprise, after 3 months, she was a little better. But after 6 months, she was much better. She was able to run, and her vision was not normal, but it was significantly improved.
Is there any definite evidence that the treatment or the improvement is due to this therapeutical treatment?
There is very strong evidence. In one patient who had a disease identical to progressive multiple sclerosis, but affecting only the optic nerves, she was near legally blind in the more severely affected eye. So she was prescribed the combination. After 3 weeks, the vision was better, but after 6 weeks, in the more severely affected eye, vision was near normal. And then so-called wash-in, wash-out studies were performed. 1 drug, 2 drugs, take away a drug. The effect was measured independently by 3 institutions, and all the institutions confirmed that on either drug alone, vision in the more severely affected eye, she was near legally blind. On the combination, it was near normal. The effect lasted the entire 5 years of therapy, after which it was withdrawn because the long-term cancer risk, although it's not felt to be significant, is nevertheless unknown.
Mm-hmm. Are there any other conditions which your thesis can assist for?
It's entirely possible. The most notable one is macular degeneration. There is a genetic abnormality in 70% of these patients, which results in a recruitment of these activated microglial cells. So that is very definite. In the other parts of the body, there's a cell equivalent to the microgliocyte termed the macrophage. And it's held that the macrophage is critical to progression in diverse diseases. For instance, the progressive scarring of cardiac valves in the spread of osteoarthrosis. The thesis, in essence, is a thesis of progression. Why do diseases progress? And it applies not only to the brain, where there's very definite evidence, but elsewhere in the body.
And why haven't there been, to the present, the advocated pilot trials?
So the pilot trials advocated by myself are in progressive multiple sclerosis with visual disability, to confirm my own observations, and in rapidly progressive forms of Alzheimer's disease and motor neuron disease. A very small number of patients are required for these trials. A robust effect, if present, should be evident at 1 to 2 years, but they must be performed by experts in trials of these diseases. Cells in the brain that die cannot regenerate, so the thesis only predicts in some patients, for varying periods of time, a lesser rate of decline. But thus far, such an effect has not been able to be achieved.
At least on the prima facie of things, I think this is very interesting and sufficient and has to be investigated further. Thank you very much, Dr. Milder.
Thank you.